3 days course, and I'd like to thank first all of you for being with us. Second, the faculty of the course. I have the course. I'd like to start with the coordinator of the course, Ms. Christine and Ms. Emiliana. She's the one arranging all administrative part of the course. And two co-director of the course, Dr. Ahmed Kuhail, he's a fellow in our ICU. He's the one arranging all the technical issues, the Zooming, the communication for the course. The second co-director, Dr. Kuntakin, she's associate consultant in ICU in King Saud Medical City. She's also the one doing all scientific material and as well as MCQ at the end of the course. And my colleagues, my friends, the speakers of the course, I will mention one by one during the schedule orientation. The course will be 3 days. Each day almost will be from 5 to 4 lectures. We are touching 2 important points. The first one, COVID-19 topics. The second one, the basic or essentials of the critical care topics which you need during your presence in ICU. The most important points you need to know, like drugs, like shock, like respiratory acute ARDS, or like essentials of mechanical ventilation. We are not relying only on the lectures we are giving. We have different modules of the course. As you can see in the WhatsApp group, we posted many modules. The video simulations, which is almost covering the, let us say, I cannot say the practical point of the course, but at least you need to know something about the airway management, about the CPR, about the intubation, and already we posted in the group. Special considerations for the patient in COVID-19, with why you are doing these procedures. The second, we have another 2 modules, one of them from Society of Critical Care Medicine from USA. This is the biggest society of the critical care worldwide. They have a course for non-ICU physician, formed of 6 modules from the fundamental critical care course and 6 modules from disaster course. We select only 6 modules to be aware about it. And I want you just to go through these 6 modules of the course. It is free online course. It is delivered by SCCM, and we posted the link. It's free. Just register, go through the modules, and it is an interactive discussion in the interactive lectures. And you need to answer some questions. Then you will go to you will continue the lecture of the SCCM course. Second module, Rashid University, Mohammed Rashid University Hospital in the Emirates. They have infection control, 1-hour infection control course free online. Or also we post this link in the group, and I would recommend to go through this one. It is very easy and attractive course. You will feel, and you will have a certificate by the end of this course. SCM, we don't have a certificate by the course. This is the 2 modules we are relying on. And our online interactive discussion in the course, and the online video streaming that you can see it now. And then at the end of the course, you will have the MCQ. MCQ to almost be 40 questions. Most of the question in the MCQ at the end of the course, it is discussed in the course or from the module of SCCM or module of Mohammed Rashid. So if you are attending the course, the lectures, it will be easy. You will feel all the question and MCQ, you have it before. We are relying on your competency actually to finish the course, and we are taking attendance once you registered in the course daily. You are entering, you are taking the attendance in every day for the lectures as well as the attendance of the MCQ. And by the end, if you did pass the MCQ, we will release the certificate by the end of the course. Sooner, and unfortunately, we will need you soon in the hospitals because we are lacking for the staffing physicians and all ICU within the cluster. The Imam Abdurrahman Al-Faisal, Al-Iman, King Salman, and King Saud Medical City. We already started to receive first batch of non-ICU physician by the May 17. The clinical part of the course, we will try to make like workshop once you are joining us. It will be orientation for most of the protocol. And we have already the cluster COVID-19 protocol for the management. And don't be worried about anything inside ICU, like medications, like ARDS, like septic shock. Everything we have protocol, and all the bedside nurse and the physicians, you will be supported by them. Feel free. I like to go through the program of the course very fast because we don't like to have lacking the time. Where this one? Yes. We can share the screen again. This is the program of the course. We'll start with the introduction now. And Dr. Shahzad, ICU consultant, he will start just after me with the pathway and definition of the COVID-19. Dr. Tasmia Asad, she's assistant consultant in the King's Road Medical City for infection control coordinator. She will talk about infection control measurement of COVID-19. I will have a quick guide for the critically ill patient with the COVID-19. After that, Dr. Waqqas, ICU consultant, he will present COVID-19 pathophysiological approach and management, a pathophysiology approach for the management. From tomorrow, we will start at 9:30 p.m. with Dr. Ahmed Kohel, our assistant associate consultant. He will talk about shock as general with fluid resuscitation of COVID-19 patient. After him, Dr. Abul Takin, she will talk about EBG interpretation. Dr. Basim Houid, ICU consultant, basic of mechanical ventilation, ARDS and COVID-19. Dr. Omar Ramadan, and we'll end with our clinical pharmacist, Dr. Bashir Abdurrahman, who will present pharmacology of the COVID-19. In the third day of May 14, at 9:30, we'll start with Dr. Muhammad Audat, acute kidney injury, pneumonia. After that, Dr. Ahmed Al-Balchi of COVID-19, Dr. Asaima, ICU consultant, she will talk about CPR dynamics, especially in COVID-19 patients, and we'll have open discussion, and we'll end, sorry, Dr. Walid, very important lecture about airway management of the COVID-19. We'll end with the MCQ by 11:30 or by 12 of the third day. The link will be sent during the course. At the end of the course, MCQ. As you can find, this is the modules, the SCCM modules, and this is the module we recommend from the SCCM course. 6 modules: airway management, basic mechanical ventilation, diagnosis and management of shock, and critical care for adult patient, management of acute respiratory distress. As well as the video we send you. So for the program, we'll try to finish on time, inshallah. It will be some discussion in between once we will have the in between. So during lectures, we'll see some discussion with the consultant. Those almost the questions will come at the end for the MCQ exam. I can now leave the floor for Dr. Shahzad for definition. Dr. Shahzad, are you available? Kindly make your microphone muted unless you are talking. If you like to talk, if you like to ask, if you like to chat, you can just raise your hand in the chat room or just send any comment in the chat room and you can. Thank you for all. Dr. Shahzad. I think maybe you are not muted. Let us see. Dr. Tasmia, you are available? No problem. I can start with my lecture until they will join. Ahmed, they are available, Dr. Tasmia or Dr. Shahzad?
Still didn't log in. I will.
Okay, I can start my lecture now. I will give you just the overall management of the COVID-19 patient until Dr. Shazad Nufar Asmiya will join. Let me share my screen again. Okay, you can see my screen now. You can write in the chat room if you can see my screen and you can hear me well. Just write in the chat room yes or no. But finally I received one comment. Yes, good. Great. Now flow of comments. Thank you so much. So until Dr. Shahzad and Dr. Tasmiyah showing up, we can go through the this lecture. It is just overall management of critical ill patient with COVID-19. Each part of this lecture will be discussed in details. In separate lecture. So I'd like to start with even the definition of the COVID-19 virus. It will be in details with Dr. Shahzad commenting about, but this is a mainly respiratory virus. In the pathophysiology, we know also it is touching the SET receptors inhibitors, SE2 receptors, which is present mainly in the lung and the other, as well as other organs, but the most important one in the lung. So coronavirus disease 2019 is a potentially severe acute respiratory failure caused by severe acute respiratory syndrome coronavirus 2. And the type of the virus will be discussed with Dr. Shahzad in details. So my opinion, this virus, it is different from the same coronavirus before. We have two SARS and MERS-CoV, but we have special or unique features for those coronavirus of COVID-19. My opinion, there is two main domains. Which one is clinical management of the virus, which until now, I can say, no any solid data or guidelines recommending any type of clinical management of the high-grade recommendation for the COVID-19, whatever the recommendation for the respiratory, for the pharmacotherapy, for even the pathophysiology, still they are doing hard to reach to the true management or solid or highly recommended management. But the most important domain, which is safety domain. Safety domain, because this virus is very transmissible. So much transmission can happen through this virus, as you can see worldwide. Of course, all of you read about this virus worldwide, and news and the media full of this one. So for my opinion, clinical management and the safety, those are the main two domains for the coronavirus. If I'm sharing with you this poll, you can tell me how you can see which is more dominant from your side. Is it the safety or clinical management or both? I can share here the domains, the polls. Let us say now you can see the poll now, right? So you can just click on safety or clinical management or both from your point of view. This is your personal opinion. It is not literature's review. It is not evidence-based. It is not recommendation from the guidelines. So from your side, I have until now voted. Still, we need 20 more. We still have 20 seconds. Is it safety? Is it the clinical management? Or both of them? Only 60% of the attendees responded. I have some response also in the chat room. So one minute finished. Agree. So did agree that both of them are essentials. Most of you they have. Yeah, I'm not giving introduction to leave the clinical management. Of course, it's important as well as the safety. But the most important for both it is the. I agree with you. Both are very essential. Why this patient of COVID-19, and alhamdulillah, not most of them admitted to the ICU, but the most of them admitted to the ICU because of hypoxemic respiratory failure, because of the most common indications, or rapid progression of the usually those patients coming in emergency department, maybe within 1 day, severely distressed, increases work of breathing, or need intubation within hours. And sometimes they coming with shock or myocarditis, and usually those patients transferred to ICU from the beginning of the symptoms within 10 days. There is some atypical presentation. I will not go through in details because the most common presentation for us is respiratory distress. The poor prognostic indicator for those cases, they divided into 3 categories. Which patient will worsening? This is dependent on 3 main categories. The first one, epidemiological categories. Of course, as you know, in Italy, the highest mortality rate because of the older people there, they are involved in the COVID-19 as the patients. So more than 65, more than 55, considering a high risk factor for those patients, as well as many comorbidities, plus the vital signs. The patient coming with tachypnea, and most of them coming with tachypnea, respiratory rate exceeding actually 24, tachycardia or desetting, and this is the main feature of the patient coming with the COVID-19. Or some of the lab investigations, very essential. When you are investigating those patients in the lab, we have some risk factor. Usually, you will find D dimer more than 1,000 nanogram per ml. You will find CPK is very high. You will find LDH reactive protein, as well as lymphocytes count will be very low. With routine over the upcoming 3-4 days after infection, they will coming very high. So this table tell us which patient have high risk of progression of disease or the duration of the disease with the COVID-19. Most of the studies, as you can see here in the China study, they found that comorbidity, mortality from COVID-19, highest among persons underlying medical condition, cardiovascular disease, diabetes, chronic respiratory disease, and the cancer patient. So usually the people who will deteriorate will become more severe, stressed, the patient with comorbidity. Very nice schedule can tell us, or table can tell us about how the chronic disease can affect the patient with COVID-19. As you can see here, this green non-hospitalized COVID positive patient, over almost 4,400 patients, this green color, the percentage, with the chronicity of the disease, with the comorbidity of the disease, which is the left side. The yellow color column, as you can see it here, non-ICU physician is admitted, but not in ICU. This blue, so the patient was severely admitted to ICU. Those are the patient in blue color admitted to the ICU. The percentage of chronic kidney disease high, 26%. So 20%, 60% of COVID positive patient with renal disease, they will admit to the ICU. But the total number of the patient with chronic kidney disease is 213. But if you look to the diabetic patient here, 780 patients of COVID positive in this study, 19% of them admitted to the ICU. So we can say the diabetes and as well as the cardiovascular disease, which is 20% of those patients, as well as kidney disease, those are the 3 main comorbidities going the patient going to the ICU. I cannot say the good thing, but you can say we have 2 peaks of age distribution for the COVID-19. Look to this diagram. We have 20 to 44 age group who is highly affected, and another age group, another peak in the age of 65 to 84 in this group. So this is the fraction of the total case. So we can affect all type of age, whatever, even the children can be infected, but the most 2 peaks of age group, 20 to 44, as well as more than 65. But if you look to this orange line, this is the case fatality rate. So the patient likely to die or dead patient over the number of the COVID positive patients. As you can see, in the young age, we have less mortality. In the old age, we have highest mortality, which can reach actually 20% for age more than 85. So the elder age more liable to die than the younger age for this disease. This is the age distribution. If I did ask, what did you expect from your point of view again? The main cause of death for the patient with COVID-19. Is it cardiac failure, or is it respiratory failure, or is it concomitant between respiratory and heart failure? We can start polls. I think we have poll for this one. Sugar stage pneumonia, multiple cause of this one. Yes. So you can see the polls now in progress. You can comment just your opinion. I don't like to also to go to the evidence-based or stuff. Just tell me, most of those patients will die because of cardiac failure, or because of respiratory failure, or because of concomitant respiratory and cardiac failure. Yes, 2, 2, 3. So the people they are writing in the chatting, you cannot vote on the polls. Still, also the number is less. We need more. Only 55% responder. We still have 15 seconds. But in the chat room, we have almost 5. So, okay, so we reach now 1 minute. So we can end. Most of you, they have respiratory failure, which is agree. As you can see, the result here, I share with you, 61% of you recommend about respiratory failure, and 29% said concomitant respiratory and cardiac failure, which is really true. Even the literature, they said 53% of the patient dying due to respiratory failure, and the 33% concomitant respiratory and heart failure. Mortality rate correlates with the age and availability of the medical resources. I'm always saying the medical resources availability one from the most important point, and you are one from the most important item of the medical resources. So we are waiting for you as a helper for the ICU. I will go roughly during for the phases of the COVID-19 patient, right? I will not go in details. Some the figures they are highlighting this as a 4th stage. Some said no, I have only 5 stage. But anyhow, whatever the theory or whatever the institution they are posting, all of them have the same item or the phase titles. The categories of the COVID-19 patients usually coming with incubation time. Those usually is asymptomatic at beginning. Then, if you start to have some symptoms, but just symptoms like fever, like bony aches, like loss of taste, loss of sensations, those will be prodromal stage. Then, if they were deteriorating more, they will go with the pneumonia with X-ray changes. Pneumonia, most of the graphs demonstrating these categories, they have 4, making pneumonia only 1. The pneumonia can be either just pneumonia with respiratory stress with chest X-ray infiltrations, or pneumonia with hypoxemia, which is most commonly coming with hypoxemia. The first categories is relying on the viral replication and the viral load of the patients. But the others from here, the category which while worsening, relying on the host response. If the patient have low immunity or have comorbidity of the old age, almost it will deteriorate. It will go more to the immunological categories, which is almost this the critical air shock patient with multi-organ failure. So most patient had, fortunately, most patient, you can say 80% of the patient in China and in the UK and the most of the worldwide, they have mild and moderate symptoms, 81% of them. Severe, 14%, critical ill patient admission, which is 5%. Unfortunately, in Saudi Arabia, we have less number than this. And even the mortality in Saudi Arabia, it is the least mortality. I cannot say the least, but one from the least mortality worldwide, which is reaching to 1.7 to 1% mortality rate in Saudi Arabia. So the severity, fortunately, we don't have a severe cases, but with a huge number of patients, the number of patients died, it is more higher than the other corona, which is all the coronavirus. Again, go back with the same categories. the clinical status. The patient incubation period usually asymptomatic, and this is the most risky people for dissemination of the infection. Asymptomatic, they are carrying the virus but no symptoms for those patients. When you start to have some fever, cough, sore throat, arthralgia, based on a friends of mine, or we have many friends in our, not in our ICU, but even the healthcare, they have symptoms. Usually they are complaining for severe tummy aches for the 4 or 5 days, fever, low grade to high grade fever, loss of sensation of the, and sometimes some of them have vomiting or diarrhea or abdominal pain. This is the prodromal stage. They are coming with the fever and the persistent fever, with the persistent tummy aches, with some sort of lethargy and chest X-ray infiltration and pneumonia and hypoxemia. Hypoxemia is a cardinal feature for the COVID-19 severity. Coming can be reached to the 50% of the room airs, can reach even to the 45%, even with the oxygen. The maximum can reach to 70-75% with the oxygen flow. If not treated and or even worsening, they can come with multi-organ failure, like shock, like multi-organ failure. So this is the severity, and I have told everyone will take it in details. This is 7 trials done worldwide, over thousands of patients. They found the most common features: the fever and the 7 studies, and the cough, as well as dyspnea. This is the most patient present the symptoms of hospital admission. If I did ask you again, sharing with me this polls, lymphopenia, as we have mentioned early, one from the most important severity parameter in the lab. Most of them you can find coming with lymphopenia group 1-8. But does it correlate with the mortality or not? Doesn't correlate with the mortality or not? So we can start our poll. I think we have it here. Initial and support for the patient intro. Who's highlighted on that row on the screen? MashaAllah, all of you are co-hosts now. You can highlight on the screen. So just write in the chat room, please. Is it true or false? Write in the chat room. Is it correlated with the mortality or not? We did agree, all of us, that it is one from the severity risk index or factors. But is it related to the okay, we don't have levels. So we rely on the chat room. Chat room to everybody, don't try. Please don't write in the screen, okay? Yes, it will continue, unfortunately, for the upcoming slides. How can we are deleting this one? Okay. Hardly I delete. So we'll go to the chat room to check your answers. False, 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 false. Doesn't correlate. Let us see. Yes, I'm agree with you. It is correlated with the you can see these two figures. It's showing actually leukocytosis. Look, this is the blue color with the patient who survived. Yellow color line with the patient who didn't survive. This was the leukocytic count, and this one was neutrophilic counts. You can see at early the patient we have leukopenia, but neutrophil count increasing with the patient who die. Non-survivor patient, we have neutrophil, as you can see, neutrophilic count increasing dramatically with the patient who die, who not surviving patients. This one for neutrophil. If we will go for the lymphocytic count, which is the more important, then we can find again the blue color, the survivor patient, The yellow color, non-surviving patient. As you can, non-survivor patient, we have very, very low decrease in the lymphocytic count with non-survivor with time. This is the days after disease onset. So you can start early in day 1 to day 3, lymphopenia, and it does correlate with the mortality. We never have lower lymphopenia, or let us can say more lymphopenia, more patient will die. Okay, so it is correlated with the mortality. Another laboratory prognostic is a strong predictor of in-hospital mortality when compared with other markers. I want to say we have many markers which can telling this patient severe COVID-19. Right? Does D-dimer one of them? We did agree for that. D-dimer is a strong predictor of in-hospital mortality. It can rely on, you can say, when you find your D-dimer going higher, your patient likely will die. It's true or false? Go with the chat room again. I think, again, please don't try it on the screen. We did agree, all of us, is it true? I think we can change the purpose of the meeting to be true. Okay, agree. So it is very easy question, and all of us agree. But let us see how is the result telling us, or the literature telling us about this point. Is it true? Look, very nice study, which is relying in a very good number of sample, which is almost 190 patients in China. Look, this is again the blue color line here on the curve on the figure. It is this one. It is survivor patient. Those the patient who live, and the yellow red color the patient who die. You can say from the day 4, the D-dimer was 0.3, increasing to 1.5, 2.6, up to 42, even very high. So whenever increasing the D-dimer, more significantly more patients will die. So we can rely on as a predictor for death if you have a patient with admission. I will again try to erase all your writing. Okay. Done. So we did agree D-dimer is a predictor. Go back again to our let us say our scheme of the categories of the COVID-19 patient. The pathophysiology, I said we have a specific lecture today about the pathophysiology of the COVID-19. Incubation period, you can find nasopharyngeal replication of the virus become positive here. Prodromal stage, nasopharyngeal replication binding to STA receptors, lung and injury, so to become positive during the time, and clinical titulation with the pneumonia. This is a cytokine storm. This is the host response in the latest stage. Immunologically, most mortality in this phase. Cytokine storm in this stage. Okay, so three dots in your screen up. Good option. Who is Dr. Abdulrahman? Thank you, Dr. Abdulrahman. Stop recording, disable participant animation. Done. Thank you, Dr. Abdulrahman. I will erase this one first. I will put the mouse back. Right. So the pathophysiology in details will be discussed with Dr. Wakas, but I'd like to highlight in this patient. This is one from the cases we have. We have ER physician intubating COVID-19 patient. His pharyngeal PCR on the same day came negative. After 7 days, he started to have symptoms: developed fever, cough, shortness of breath, admitted for pneumonia and chest X-ray, as you can see it here, and started hydroxychloroquine and azithromycin, which is again many queries currently about the medications to be touched in detail with the pharmacotherapy with Dr. Bashir. Azithromycin. Nasopharyngeal swab taken on day 7. Right, he was symptomatic for PCR, which is repeated and became negative again. What's your action in this stage? What you will do? then share it again. Now to erase everything, you can unshare and I'll share again. Okay. I'm about to finish, so almost I will not disconnect it again the screen. Thank you, Dr. Abdurrahman, so much. So what's your action here now? First, you will discontinue hydroxychloroquine and continue ceftriaxone and azithromycin as you diagnosed him, excluding COVID pneumonia, and you are dealing with the CAP, or discontinue hydroxychloroquine again and upgrade ceftriaxone to dazosine, or continue same management. I think I have it in the poll. Or continue same management, or do bronchoalveolar lavage and repeat PCR, and the number 4, continue same management and repeat nasopharyngeal swab again. Maybe this one, not this one. Okay, let us share in the chat room. I can say 4, 4, 3, 3. So we can say most, half of you, but the majority going with 4, and so between 3 and 4. So we still have on the clinical base the patient is COVID pneumonia. We did agree for that. But so 1 and 2 excluded almost. 3 and 4, this is COVID patient, COVID pneumonia. Shall we go with the bronchoalveolar lavage with the patient with COVID pneumonia, or we repeat and we can consider 2 negative swabs false positive? Bronchoalveolar lavage or bronchoscope as general, one from the most aerosol generating procedures. So it's better to avoid it as much as you can. Not only that, still have many patients come negative, false negative with the COVID-19, with the PCR. So if you then look at this table, you can find 2/3 of the nasal swab only positive, which is 63% nasal. The first sample this physician take pharyngeal swab. Nasal swab 63% sensitivity. Yes, bronchoalveolar lavage 93% sensitivity, but we are not doing bronchoscope for a patient who doesn't need bronchoscope. And he have typical signs and symptoms of COVID-19. So I can repeat the tracheal aspirate from EDT. No, not nasopharyngeal, tracheal aspirate from EDT. So it can come positive. So the message here, don't rely on 2 negative samples of nasopharyngeal swab or pharyngeal or nasopharyngeal swab, and you have the patient intubated, and you have features or symptoms or signs of COVID pneumonia. So you have to rely on this. Again, will be discussed in details with Dr. Ahmed Al-Bashi in pneumonia, but I want to say this is the PCR. It can come positive from day 0. The blue color, this is the PCR. Even asymptomatic patient can find some positive with some false negative results will come through it. And day 14, the red color is IgG and the green color IgM. We can rely on. So even in the interpretation of the diagnostic testing for COVID-19 patients, if you have PCR negative, so consider those are false negative patients. Whenever you have clear clinical signs of COVID-19 patient, either go with the tracheal aspirate or bronchoalveolar lavage. If it don't go with diagnostic, for the in highly emergency case, you can do bronchoalveolar lavage. Again, this table will be repeated in details with Dr. Ahmed Al-Bashi. So going back again to our schedule. So the management, of course, incubation period, we have nothing to do with our patient, only observation and tracing all his contacts. This is what we are doing currently. It can take up to 4 patients. According to the protocols, some centers going with hydroxychloroquine, sometimes going with not. So what we have in our ICU, which is the Ministry of Health protocols, we are starting for any positive COVID patient hydroxychloroquine since the beginning. I don't know if this one will be updated sooner or not because of the most of the trials. I will not touch in details again. The pharmacotherapy will give you the details about the pharmacotherapy. We can add logonavir, ritonavir. This is again based on the MOH protocol. agree or not agree about this one, evidence support or not support, still we are going with the expert opinion, and we can use interleukin 6 or some sort of the tocilizumab in the third stage with steroids in ARDS patient, also again in pharmacotherapy with another novel modalities like convalescent plasma or plasmapheresis. So the management, this is again, this is a quick guide, it's not the details. Every one of them will have the details discussion later on. So this is again exactly the same plant characteristic of the COVID-19, organ failure, hypoxemic shock, and acute kidney injury. This is the blood we mentioned in details in the blood. Imaging, I want to say in imaging, I want to highlight, we have different imaging to be done for the patient. Don't go, we are not going as routine for the patient for CT for diagnosis currently. Again, limiting the transportation of the patient as much as you can. X-ray, of course, peripheral opacities, ground glass appearance, and the ultrasound now or focus we are doing in our team for all patients, which can very diagnostic and confirmative lung ultrasound with diffuse baseline profile. Echo, something very essential. I just want you to remember too, if you're going with the CT, there's some exclusion for the CT. If you find diffusion, if you did find cavitation, so all of this against the patient with COVID-19. Airway management will be discussed in detail with Dr. Omar Ramadan. We'll talk about acute respiratory failure. There's some precautions even with the oxygen therapy, with the nasal cannula, with the face mask, with the non-rebreather mask, with the high frequency cannula, with non-invasive ventilation until you will come with the intubation and the ventilation. Mostly volume control and relying on the pathophysiology now of the disease, which phenotyping, it will come in details. And intervention, as we have mentioned, the routine protocol. Again, don't worry, we have protocol for COVID-19 touching every these details. Renal, we have a special lecture from Dr. Muhammad Audat about the acute kidney injury with COVID-19. As we have mentioned, medications, whatever steroids, antibiotics, or antiviral or modulators, or any novel therapies, also we are going through it in detail with pharmacotherapy. So this is a quick guide of the COVID-19. And you can see many guidelines coming now to the floor, either survivor sepsis campaign guidelines, or Canadians, or Australian, or British NHS. Most of the guidelines, they don't have solid evidence for the parameters, but most of them sharing the same concept as we have mentioned earlier. But this is the most robust one, which is surviving sepsis campaign, and we have to browse actually, because the first author of this guideline, Dr. Waid Al-Hazzani, is from Saudi Arabia, and he's the methodologist and researchers in McMaster, and he's the one leading the guideline grading worldwide, surviving sepsis campaign guideline. So this is the quick look for the course of the COVID-19 patient. And our lectures in details later on will touch each one in details, right? So I can open the question until screen sharing is stopped, no problem. So you can have the question if you like now. We are ready. What is our role as non-ICU doctor during the upcoming days? Very good questions, Dr. Abdurrahman. Dr. Abdurrahman, can I ask you are from the which hospital? King Saud or Imam Abdurrahman Faisal? Orthopedic department, King Saud Medical City. Very good. Welcome, Dr. Abdurrahman. I can tell you the plan now, briefly, the plan. As I told you, we'll start to receive non-ICU physician to working inside ICU from the May 17. We did this is the 5th course to do, or the training program to do for non-ICU physicians. We have almost now a list for a very eminent and eager non-ICU physician who would like to support us during this pandemic. We have a plan according to the phases of the surgery plan of the phase of the cluster. Will start phase A2 sooner by next week when the number of the cases increasing in the Imam Abdurrahman phase, the first hospital receiving the patient of COVID-19. Once it will full, it will be shifted to the Iman Hospital or King Saud Medical City. Even our center as King Saud Medical City now, it's not the center of care for COVID in this stage, but even though we still have many patients in our isolations. Right? Our ICU staffing from consultant, registrar, senior registrar, and fellows, they are covering all the clusters. And so 2 weeks back or 3 weeks back, we start to send our consultants and our ICU physicians to Imam Abdurrahman al-Faisal, to King Salman Hospital, to Iman Hospital to cover there. So we are suffering now from the shortage of our physician inside our ICU, right? So we will start to retrieve or to take your support and help sooner. It will be on phases, maybe every 2 weeks we'll receive a new batch. And in each hospital, we will prioritize their non-ICU physician. For example, if we have orthopedic or GS or telemedicine for Imam Abdurrahman, they will cover Imam Abdurrahman ICU. From Iman, they will cover. If not enough number from their hospital, maybe we'll send our staff also to help them there, because we are working in the cluster as one group, right? Your rule, first few days, we will do, for the first batch will come, we'll do like, at the beginning, before you will joining, we'll do like orientation Zooming meeting. This orientation will give you the policy, protocols of the ICU, protocol of the COVID-19, your assignment, your allocation inside our ICU, and you have a physician affair inside our ICU with Dr. Omar Ramadan. He's the one doing the schedule and the route. You will be linked with one of ICU physician almost for a week. In non-COVID area, we still have 70 beds, non-ICU full of non-COVID patients. You will start working in this area. You will help the ICU physician. You will be attached with one of our ICU physician for a week to know the file, how to write the plan, how to discuss the case, how to transfer the patient out, transportation of the patient. You will help him how to enter the medication. So you will know your rules during this week. As well, we can do some workshops like airway management, like basic or essential mechanical ventilation while you are joining inside our ICU. Once you need to join the COVID area, you will join the COVID area as a support. So the plan, or let us say the module of a unit of the ICU for COVID, if we have 25 beds for ICU, they will be covered by 2 ICU consultants 24 hours. They will be covered by 2 ICU specialists, and they will be covered with 8 non-ICU physicians. So each non-ICU physician will handle 6 beds. This is in the peak of the COVID-19 patient. 6 beds, non-ICU physicians supervised by a specialist. So 2 non-ICU physicians for 12 beds with 1 ICU specialist with them, with 1 consultant with them, right? But the preparation to that, it would be a non-COVID area first. Okay, great. Any more questions about? And again, before you will joining, we'll do orientation for everyone joining ICU. Thank you so much. I can now, Dr. Shahzad is available, right? Boss? I make him a co-host. You can. Unmute. Boss, you are here. Welcome.
Yes, Dr. Mahdi, now it's fine.
I make you co-host, by the way, earlier, so you can unmute yourself. But anyhow, welcome, Dr. Shahzad. Sorry, I didn't start because my lecture is supposed to be the 3rd lecture today. I just went through highlights because we were not available during the time. For example, Dr. Shahzad is one from our very active consultant working in us in our ICU, and he's now covering the King Salman Hospital. ICU. So welcome, Dr. Shahzad.
Dr. Mahdi, I think there is some default that
your voice is, you can make it loudly.
Yeah, I think there is some default in that I cannot share my screen because I have been logged in with two. Even I'm using only one device.
Sorry, I cannot hear you well.
Okay, let's go, man.
Again, the problem came to my mic. My mic was low. My speaker, sorry. I think he went out and he will come back again. Yes? My speaker was low volume, so I didn't hear him well. You are now here, available, boss? But I searched it in participants. I didn't find anyone. No problem. Okay. Again. Dr. Jensen.
No, so make him host. Yeah, it's okay.
I will make you unmute and make me a co-host.
Dr. Mahdi, I cannot share the screen. I think there is some problem. So I will ask Ahmad Kohel to share my screen.
You can send me, no problem. I can share with you, or if you like,
it's
I
with
can make you
Ahmad.
co-host.
Yeah, it's
you are
with
now co-host.
Ahmad. No, I am not co-host.
So just give me a minute or a second. I will do co-host. If you allow me, I will make. I cannot do one more. Plus, Ahmad Kohel available because he's the host. He's the only one can make you co-host.
Ahmad has made Saima as a co-host.
Yes.
आप कर सकते हैं करें.
Kohel.
Now Kohel joined.
Now yes, now he joined and he make you now. Make me host Kohel and I can arrange and you can take rest. Kohel, he joined with two devices, one of them host, one of them co-host.
Yes.
He did or not?
I think Ahmad Kohel can do two things. Either he can make me co-host or he can share my presentation then. But if he make co-host, it will be more better. Okay, I think my voice is clear, Dr. Mahdi?
Yes, clear now. Okay.
So, meanwhile, Ahmad makes me co-host. I can start some words.
Yes, you can. The screen is yours.
Right. Welcome to all participants and the colleagues who are joining this course. This is our 5th online course for the non-critical care ICU physicians. And the first time I was able to listen the lecture before my lecture. Otherwise, after introduction, I was having the first lecture to be presented, starting with the very basic. But really, I enjoyed the first lecture of Dr. Madi, a bit advanced lecture, but full of clinical knowledge. I think the panel or participants who have joined this course, probably they are more expert and probably they have enjoyed the lecture and informations of Dr. Madi. Really, it was very useful and clinical point of view and from the now it's all topic fine in South medical other hospitals of the C1 cluster that will go to describe that how if the non-critical care physician ICU joins, how he can help the ICU department and ICU physician. So this is my lecture. I think if anybody has any problem in the sharing of my lecture, so I will stop on the first screen. If any problem, just let me know in the chat.
So Shahzad, sorry, still the voice is not clear. The streaming of the audio.
The lecture is clear. We're going back. Yes, Dr. I will try my best, Dr. Madi. Now it's clear.
That's good. Okay.
Right. Okay. I think since morning there is some problem in the mobile network as well, which
yes. Almost like that.
Yes. Yeah. So if any problem, Dr. Madi, interrupt me. I can repeat the informations which I am going to deliver. So I will request the admins to take care of the timings because I'm going to start at 10:30 p.m. So my lecture is going to have a case definition and pathways. And dear colleagues, I will say that Dr. Madi lecture was advanced and it was very interesting. But we will start the course with the case definition and pathways. You have heard the advanced forms of coronavirus, which is occurring into having, as Dr. Madi was telling about the incubation, prodromal phase, pneumonia, and immunological phase. Very interesting. But we will go before this, that what's going to happen when a patient who have a symptoms or who don't have the symptoms of coronavirus. And what is coronavirus? The thing is that the coronavirus, probably now every layman knows about the COVID-19. And of course, the healthcare care workers also knows about it. Even I will say that the layman people now get fatigued and having a corona fatigue syndrome. But Alhamdulillah, we the healthcare workers daily are trying to update ourselves because we have to treat the patients. We have to treat the sufferers. So that's why we are here today. I am learning. Even with all of the lectures, we are updating and I am every week learning from the lectures that are coming, and it's very, very beneficial. So today, my lecture, about 30 minutes talk, will include introduction, application, what are the signs and symptoms, defining the case definition from Ministry of Health Saudi Arabia, and the pathways, how the patients are getting admitted or discharged or isolated. At the end of the session, we will be able that what is coronavirus, why it is called COVID-19, what is according to percentages, pathways of action from ER to critical care department. We start with the family. I think everybody knows the coronavirus has a family. It constitutes family. Family has coronaviridae. It has coronaviridae as well, but coronaviridae has 4 kinds of genus: alpha, beta, gamma, and delta. and its subfamily is Orthocoronavirinae. Coronavirus COVID-19, which is a novel coronavirus, belongs to the beta group, and beta has two subclasses. It belongs to 2 beta. These are enveloped viruses. So we know that the coronaviruses or viruses usually have single-stranded or multiple-stranded. Some are enveloped and some are non-enveloped. So coronavirus is the enveloped virus with the positive sense single-stranded RNA genome. The word corona and the picture depicting in the slide is showing there are multiple red-colored crowns, needle-shaped surfaces are there, or club-shaped spikes are there. These are usually viewed over the electron microscopy. And corona, taken from the Latin word called crown. This COVID-19 is not new. There were, before there was families of coronavirus was there. They didn't caught the pandemic, but they were lethal in some relatively high-risk countries was there. It was in South Korea, it was in Saudi Arabia as well at some time. If we see the outbreak in 2003, severe acute respiratory syndrome called SARS. SARS outbreak was there, though the mortality was there, but it was like an endemic was there. 2012, Middle East respiratory syndrome coronavirus, which was having an epidemiological link with the camels. It was there, mortality was there, and still the cases are sometimes coming. Mostly these cases were in the Middle East, and most of the case came in Saudi Arabia as well. 2015, almost the same species of MERS coronavirus was appeared in South Korea as well. And 2018, again, there was outbreak of MERS coronavirus, even it involved the Hajj and Umrah seasons as well. And now we are talking about the 2019 and 20, when there was in the month of December, middle of the December, a pneumonia outbreak was reported in Wuhan city of China. And 31st December, the WHO was able to define that it's characteristic like a novel coronavirus, which is quite resembling with the SARS-CoV-2 with the International Committee of Taxonomy of Viruses. Look at this slide. Most of the people get infected with COVID-19 have acute respiratory illness. Dr. Madi has very well signs are coming. We will see up in the trend of the course is coming to share the data that how the cases are picking up. The 5th April, our first case when the cases was 1 million all over the world. And just imagine
that. Never mind. Excuse me. You can just repeat the previous slide because and make slowly, and the voice was not clear in the previous slide. They asked it to repeat if you never mind. Thank you so much.
So this slide is clear now. This is the previous slide of Wuhan.
No, this is slide. This is slide. Okay, just repeat, but slowly, and because the voice was not clear.
Right. So I was discussing that when WHO labeled it is that this coronavirus is there, it was a resemblance of SARS-CoV-2. The SARS virus appeared in 2003 outbreak. So this time when it appeared in December 2019, like a pneumonia outbreak in the Wuhan city of China, WHO named it as 2019 or 19 novel coronavirus, resembling the SARS coronavirus as it was 2003. Now, if we go with this slide, most of the people get infected with COVID-19 have acute respiratory illness, like dry cough, fever, and shortness of breath. Some people report as mild, and as Dr. Madi was telling, mild to moderate symptoms. It's almost the 80% of the people symptoms of coronavirus. Look at this chart. This is starting from our first course, which was held on 5th April. The cases was 1 million. Mortality was 50,000 cases all over the world. We were doing the course after every week, and once today we are doing the 12th May 5th course, 4.2 million people have been affected, and the mortality is 287,000 people more died already. Still, we are learning about the coronavirus, how to manage it clinically, and how to get the more and more knowledge about COVID-19. As Dr. Mahdi tells, the mortality in Saudi Arabia is 0.8%, but still the cases are there. Critical cases are also there. In the world, the mortality reached up to 7 to 8%. It has a unique pathogenesis. It is affecting with the upper respiratory tract infection. It is affecting with the lower respiratory tract infections as well. And as I told, it has a zoonotic origin, 96% similarity to a bat coronavirus. So it's widely accepted that it is originated from the animal origin, like bat origin, but still the definite source is not elaborated by WHO. It is caused by SARS-CoV-2, which was an outbreak in 2003. And the Wuhan strain has been identified as a new strain of beta coronavirus from group 2B. As we discussed, 4 groups: alpha, beta, gamma, and delta. So it's from the group B and 2B. Let's discuss about the mode of transmission. Modes of transmission, that is an important slide to discuss what kind of mode of transmission is there. Is the primary mode of transmission is via respiratory droplets that the people exhale. Now, respiratory droplets is of diameter, we have to consider the diameter. Some have more than 5 to 10 micrometer diameter. It's called respiratory droplet. And if it is less than 5 micrometer, it is called the droplet nuclei. Now, the last evidence that COVID-19 primarily transmitted between the people through respiratory droplets and having a roots as a contact roots spreading the mode of transmission. So respiratory droplet as a contact roots. Now it occurs when a person is in close contact within the 1 meter, 6 feet, coughing, sneezing, mouth and nasal mucosa are shedding the viruses, or through the conjunctiva as well. So was having a respiratory droplet, having a contact routes of transmission. Query airborne. Airborne is still, if we say that is the airborne is a way of transmission, probably the answer is no, as a generalized point of view from the public, because it is less than 5 micrometer. It's called droplet nuclei. The microbes remain in the air for a long period of time, and it can be exhaled more than 1 meter. But who will take care of airborne precautions? The healthcare workers are the number one, because there are some studies have been done when there is aerosol generating procedures are being done, it can spread. And it has been done by the experiments in the real situations as well. So there is, from the WHO, mode of transmission airborne in the general is not defined till now. They are very careful to define, but in the healthcare workers is needed to consider the mode of transmission as airborne as well. There is 3 or 4 studies that patients came with atypical presentations, like having intestinal manifestations, diarrhea, nausea, or vomiting. It has been considered that probably it has a fecal-oral route as well. Now, as we are talking about the airborne precautions, the droplet nuclei, when the person is affected by coughing or sneezing or touching the surfaces, like thermometer, like stethoscope, like the things in the hospitals everywhere, if the person is touching or coughing, it can remain there and it can be transmitted. So that's why the disinfection of the surfaces must be done with the substances like ethanol should be applied on those surfaces to disinfect that place. So this was the mode of transmission. Incubation period, very well explained by Dr. Mahdi. Incubation period is that the person infected with COVID-19 and then having a manifestation of the symptoms. Usually it ranges from 1 to 14 days, but some of the cases, it is observed that it can extend it up to 27 days as well. Remember these days, it is most commonly 5 days, and the 5th day, it has some manifestation, because we will discuss in the last slide that how the incubation period is affecting the terminating the isolation of healthcare workers and terminating the infection from the general public as well. Signs and symptoms are non-specific, and those infected may either be asymptomatic or can have a flu-like symptoms. And they can have fever, cough, fatigue, shortness of breath, or muscle pain. Atypical symptoms are mostly common with the immunocompromised patients, and it dealt with the nausea, vomiting, and diarrhea. Look at this slide. Patients are coming with the severe symptoms like getting a high fever, dry cough, features of pneumonia, whether it is upper respiratory tract or lower respiratory tract. Respiratory droplets containing the virus can remain on surfaces even after the ill person is no longer near. That's why disinfection of that surfaces is important. If we go with the percentage, that how much percentage in the signs and symptoms, the fever occurring in the 87.9% of the people, while dry cough has 67.7%. There are other atypical symptoms as well, but look at the shortness of breath. It is involving the upper respiratory or lower respiratory tract. 18.6% shortness of breath people are being presented. As Dr. Madhi was getting in the pool as well, hypoxemia, respiratory failure is the cardinal symptom is going on in these cases since this COVID-19 is coming. Look at the nausea and vomiting. It's not common, but uncommon sign and symptom is there that the 5% of the people can come with nausea and vomiting as well. Last, conjunctival congestion, 0.8%. 0.8% signs and symptoms are coming only with the involvement of conjunctival congestion. That's why healthcare worker must care of the eye or conjunctival spread as well. Now we come to the case definition. How we are defining that this can be a case of COVID-19 to suspect. And then right side of the slide and the left side is the epidemiological link. Clinical presentation is 3 symptoms we have to take. This is the standard Ministry of Health released protocol, which is defining for all of the patients across the kingdom that how we have to suspect the COVID-19. Clinical presentation is 3 symptoms: fever, mild or by history, cough or shortness of breath in the 14 days prior to symptom onset, and he met at least one of the following epidemiological criteria. So clinical presentation, either fever, cough, shortness of breath, and having any one of the epidemiological link in the last 14 days prior to symptom onset. What is the epidemiological link? Had a history of travel abroad. After 12 or 13 March, probably we don't have the patient now with the history of travel abroad, except some exceptional cases. Or the person have visited the high risk area of the kingdom, like Jeddah, Makkah, Medina, Riyadh, Dammam, Qatif. These are the high risk area in the kingdom. If he visited there and came back, that is epidemiological link. Or he is working in a healthcare facility, or he has a close physical contact with the confirmed COVID-19 case. If any one epidemiological link is present, it will go to highly suspect the patient with COVID-19 if he is presenting the symptoms of fever, cough, or shortness of breath. The second clinical presentation in the hospitals, if the patient is presented or admitted in the hospital with unexplained community-acquired pneumonia or hospital-acquired pneumonia, suspect the COVID-19, of course, there will be some clinical parameters or radiological parameters to explain that why it is an unexplained, or the patients with atypical presentations in the immunocompromised state needs to suspect and to investigate for COVID-19. And this thing does not need any epidemiological criteria. What is confirmed COVID-19 case definition? Who has been suspected and by the laboratory PCR method or diagnostic investigations done and it came positive, he is the confirmed COVID-19 case. How we define the close contact? Close contact is the person like healthcare associated exposure, working with the patients or delivering the direct care for COVID-19 patients, living with the person who is already COVID-19 positive, traveling together in any kind of traveling, by air, by land, with the COVID-19 patient, it is a close contact, and living in the same household as a COVID-19 patient is defined, it is a close contact for the COVID-19 patient. Clinicians must keep an eye over the atypical presentations, like I told, immunocompromised patient, post-transplants, renal failure, congestive heart failure, HIV, patients with the hepatitis. They can come with the atypical presentation. So we should keep an eye with the atypical signs and symptoms as well. This is the respiratory triage checklist. It is present most of the hospitals in emergency departments. In the ED, you will see the same as we have previously slides defined how to suspect COVID-19 patient, clinical presentation, and epidemiological link. If we see this chart, epidemiological link scores 3. While sign and symptoms, every sign in pediatrics scores 1, in adults scores 2. So any patient who is coming with the epidemiological link 3 and he have only one symptom like fever, and it will score 2, 3 plus 2, 5. So any patient who is getting the score more than 4 needs to be suspected. He should have hand hygiene in the ED. Let him to wear the surgical mask and direct him through the respiratory pathway to the pulmonology clinic. So this respiratory triage checklist is there to suspect that how we can have the scoring. If it is a high score more than 4, let the patient to attend the pulmonology clinic. Now, after the visual triage, if we get the case definition, then we will see either this patient is stable or unstable. Unstable means, does he need any immediate life-saving procedure like intubation or this one? Then he need to be having the resuscitation room or observational unit where the life-saving procedure can be done by the ED airway team or by the ICU airway team. And if the life-saving procedure has been done, immediately evacuation must be planned from the ED to the respective departments. If he doesn't need any life-saving procedures, then he will be in the pulmonary respiratory clinic in the ED, will be assessed either this patient is stable or unstable. If he's stable, fit for home isolation, take the swab, notify MOH, and let him to go home for home isolation. What we mean by stable? If his respiratory rate is less than 20 per minute, if his X-ray is quite clear, if his oxygen saturation is more than 92% on room air, he is a stable case to be discharged and for home isolation till they get the results of swabs. If he is not fit for home, bed management must be informed. He must be admitted, direct admission into the ward or respective areas according to his stability. Now we have the next slide. It is an admission pathway. The orange colored is almost the same that we are discussing the clinical presentation and the epidemiological link. Once its score is high, then we will assess this patient after this visual triage in the ED. Does this patient is stable or unstable? His clinical status and its radiological status. If the third green color graph column is showing that critical case is suspected, now he will be assessed whether he needs any life-saving procedure or not. If he needs, so first of all, life-saving procedure must be done and stabilize and admit the patient to ICU isolation within 15 minutes. Now, within 15 minutes, we can say that the patient needs admission, assessment, and all this one. Admission can be done in the emergency or the ICU department. Let medical on-call must accompany the patient to ICU and begin the admission process from there if not done in ER. There are specific beds in ICU, there is specific ICU teams, and the time is minimum. Within 15 minutes, we need to shift the patient to the critical care department. Where the respective areas will take the nasopharyngeal swabs for COVID-19, and it depends upon the clinician that if he wants the samples for MERS-CoV or H1N1. But most of the days now, we are not linked with MERS-CoV and H1N1 because if we send the sample, we are not getting the results. So COVID-19 is the priority. We call 937, fill out the COVID-19 form and get the Hassan number, transfer by the SAMHSA, and then MOH is getting the result and local infection control people can be followed. If it is positive COVID-19, you will treat as per COVID-19. Dr. Madi, mashallah, he has detailed, and there will be some other lectures in the course where there is specific that what we are going with the treatment according to radiological, lab, and clinical condition of the patient. But if it is negative COVID-19, then we can decide for the isolation, that how we can get the isolation. Now we were discussing that there are physicians from Iman, Salman, and Abdurrahman bin Faisal Hospital, and from our hospital as well. There are different phases to have the COVID-19 patients. Like in the phase 4-5, Imam Abdurrahman bin Faisal Hospital is the hospital which is designated for COVID-19 patients. Now there are some cases are in KSMC as well, in Iman, but till the space is there, even from King Salman Hospital, with the positive case, we are transferring to that designated hospital of the cluster. It is either is a quarantine unit or designated C1 cluster hospital. What happens? That there is COVID-19 result positive. Immediately, the crisis management team is activated with the hotline. It is the nurses which they are doing the things how to quick discharge to that specific hospital. The medical physician is going to write down the medical report. It must be sent immediately to the EHALA system, and at the same time we can call the respective critical care or national command center respective people as well, that this patient is positive, medical report is written, and EHALA number is this, we want to transfer the patient. At that time, crisis nurse management is doing, they're arranging the specific ambulance, specific transfer team is there, and they are taking care of the proper PPEs, and after a patient also will go like a capsule in a specific specific PPEs or specific capsule things can be done to transfer the patient. After this coordination, sending the medical report, activating the transfer team, and once transfer has been taken, these physicians or team must be kept in under the observation whether they have any symptoms or not. We will coordinate with the security people to clear the area once appointment with ambulance is ready. Duration of isolation precautions pathway. Now we know suspected cases and the confirmed cases. Confirmed cases up to either it is symptomatic or asymptomatic. If patients are symptomatic, we will do retesting of COVID-19 every 72 hours. And once the first sample comes negative, we will do 2 samples 24 hours apart. If both are negative and patient clinically stable, can be discharged for home isolation. For 14 days, for 7 days, now the local infection control, Ministry of Health, they are following the patients and with the command and control centers. If the patient is asymptomatic, retesting every 72 hours after confirmation. Once get the first negative sample, the other sample will be taken at the 24 hours. If both are negative, will be discharged for 14 days at home isolation. Now we come to the suspected cases. Suspected cases will become confirmed if initially with COVID-19 PCR positive. If suspected case now clinically stable or clinically unstable. Clinically stable, as we discussed, home isolation or isolation in designated facility may be considered based on assessment by the designated health inspector or the persons from the command and control center. If the patient is clinically unstable, must be admitted to the hospital for isolation at least for 14 days. We have the last updated on 2nd May, return of healthcare worker if he is infected with COVID-19 patient. The source is CDC and our Saudi Disease Prevention Control Center. If the healthcare worker is asymptomatic, get retested for COVID-19 at 3rd day of confirmation. So the first sample come positive, retest him if he's asymptomatic on 3rd day of confirmation. Once his every 3rd day can be done, once it's first sample negative, we will do the another one, second consecutive negative swab. If it is negative, he can return to the his duties. If he has symptoms, if he's symptomatic, then it should be retested 2 days after the resolution of the symptoms. So he get cured, his symptoms off. After 2 days, we will retest him. The first sample came negative. We'll do the second sample 24 hours apart. If both are negative, he can be back to work. Now, if both A and B, symptomatic or asymptomatic,
Boss, 2
exceed
minutes,
the
yeah, boss,
time.
if you never mind, okay?
Oh, yes, inshallah. Inshallah.
Thank you.
If healthcare worker is exceeding the time above, like symptomatic or asymptomatic, and it goes more than 5 days, then we rely only on one negative sample taken. If it is negative, it is enough to return to the work. Yes, once he is coming back to the work, all the people, when there is negative, we say that they completely wear the face mask to control the source control, and he must self-monitor himself that if there is any symptoms reoccurs, then he needs to be contacted with the infection control team. Of course, these are the guidelines taken from the Ministry of Health, Disease and Prevention Control Center, Command and Control Center. Never forget that there are local infection control policies are there, infection control centers are there. They have their own systems of tracing, testing, and getting the results and finishing the isolation pathways as well. But this is the standard which have been applied. In some atypical cases, infection control is regularly seeing these things. Thank you very much for listening. I hope you enjoyed. If any questions, send me in the WhatsApp, in the chat up now. This is a KSMC COVID-19 hotline. Regular local call is there, and the mobile number is there. So thank you, Dr. Madi. And sorry between the interruption if you find it out. And now time for questions or for the next lecture. Any questions, specific questions, please? So, Dr. Madi, I think
Yes, boss.
Again I will say that either the people understand all the lecture.
No, but he looks like understand all the lecture, yes, boss.
Alhamdulillah. That's great, Dr.
Yes.
Madi.
Thank you so much, actually, always.
Welcome. I am available, Dr. Madi. If any question came, even I can reply the person in his inbox as well.
Now, Dr. Amir asking, in symptomatic patient, you said if positive, repeat every 72 hours.
Yeah, I think this is very clear in my slide, Dr. Amir, that every 72 hours means, first of all, he is symptomatic, positive and symptomatic. So we will wait till the resolution of the symptoms. Now the resolution of symptoms are there, he's clinically fine. We will do the retesting. Now we did resolution of symptom 1, it came still positive, but he's become asymptomatic. So we will do every 72 hours till we get the negative. Once we get the negative first, we repeat another one. There can be timing difference between the collection of results, but the sampling must be like this. Yes, Dr. Amir, you're right. The result need more 4 and 5 days, but the sampling can be done. For example, you did the sample today and it's negative, and now you did another sample 24 hours apart. Maybe you will get the result 4 or 5 days later, but it will be considered that the second sample is negative. I will go with the personal experience because we are the critical care. Sometimes we exposed ourselves to the cases as well. With the asymptomatic, persons, like we did our swabs, we usually get the result on fast track because the exposed to the patient. And if it is negative, maybe it will take 4 or 5 days. But if it is positive, the person gets the result within very, very quick, 24 hours or 36 hours, because they immediately reply you. For the negative, they take time to release the results. False positive, Dr. Talal, with the PCR is the most sensitive test. So mostly it goes with the more true results. Sampling, is there any? Ah. Sampling, as Dr. Mahdi told, that bronchoalveolar lavage has sensitivity of 80%. But I mean, we usually don't do. We do the nasopharyngeal swabs because of the shedding of the viruses in that area. So we take the sample as a nasopharyngeal PCR. Any other? What about if the PCR negative by nasopharyngeal? But I think the PCR is most sensitive. So we rely more on the PCR rather than IgG, IgM. And according to my knowledge, that still in Saudi Arabia, we don't have IgG and IgM. I think Dr. Tasmia can more explain in her lecture, but IgG,
This
IgM.
boss, this issue will be I posted in my slide about the curve of PCR and the IgG and the IgM. It will be discussed in details in Dr. Ahmed Al-Balshi pneumonia with COVID-19 patient. It will be discussed in details. But if you have PCR negative and nasopharyngeal but positive IgG, IgM, you have to think about false negative PCR.
Ah.
Okay, boss. Thank you so much.
Thank you, Dr. Mahdi. Thank you.
Great job. Thank you. Now, thank you, Dr. Shahzad. Now we can go for Dr. Tasmia, one from the most important lecture about the infection control principle of COVID-19 patients.
Assalamu alaikum. Assalamu alaikum, everyone. Can you hear me?
Yes, yes, Dr. Tasmia.
Yes, yes. So,
Yes, your voice is clear.
okay, my slides are seen or not? Are my slides visible?
Yes, Dr. Tasmia, make it slideshow.
Okay. Is it okay now?
Yes, it's okay. Please start.
So, assalamu alaikum, everyone. Thank you, Dr. Mahdi, for giving me an opportunity again for talking about the infection control, prevention and control recommendations for patients with with novel coronavirus. So, in my lecture, my main objectives would be to show or to demonstrate how to wear appropriate PPE and what kind of PPE to be worn to perform hand hygiene and the donning and the doffing techniques. So with this, we could safely and confidently connect with COVID-19. So according to the CDC guidelines, definitely you need to follow the following precautions, which include standard precautions, contact precautions, airborne, which includes even eye protection. So this is definitely a droplet borne infection, which mainly spreads by droplets. However, in case of aerosol generating procedures, which I will be talking about, you need to use your airborne precautions, which includes your N95 mask and the face protection. So to start with, as everyone knows, hand washing is the most important and the easiest method to reduce the transmission of pathogens. However, the soap and water is the most important thing. If you don't have it available, you can go for alcohol hand rub or the sanitizers, which are readily available. And it is important that they have a certain percent, that is 60 to 70% of alcohol in them. Now, when you do your hand hygiene is during your 5 moments, which is before you actually encounter a patient or you touch a patient, before you do any clean or aseptic technique, after you come in contact with any body fluids of the patient, after you finish touching your patient, or after you have touched any patient's surroundings. So these are the 5 moments when you need to do your hand hygiene. Now, how the various steps of doing hand hygiene as depicted here, it's very easy to demonstrate rather than to describe. However, this is the WHO sequence that we generally have to follow. So make sure you follow these steps, which includes taking a handful of amount of the alcohol hand rub onto your palm. The first step includes rubbing palm to palm, and then the second is rubbing the palm to dorsum of the hand and vice versa. third is with your fingers interlaced. So whenever you're doing these steps, make sure you apply appropriate friction so as to you need to apply friction so as to clean your hands or to do these steps appropriately. 4 is to rub your back of the fingers to the palm, then grasping the web space of your thumb, you clean your thumb, and then your tips or the pulp of the fingers onto your palm in a rotating motion forward and backwards. And the last would be your wrist. However, there are certain prerequisites that you need to meet before you go about doing your hand wash or your hand hygiene. This is making sure that your nails are cut, all your jewelry is removed, or you remove all your wrist watches, gadgets, everything, and also make sure that your wrist is exposed. So these are very important, especially before you go about doing your hand hygiene. Now, the duration of hand rub, if you're using hand rub, it is 20 to 30 seconds. If you're washing your hand, it has to be double the time, which is 40 to 60 seconds. And when exactly would you prefer to wash your hand is when you have your hands soiled with blood or body secretions, okay? So this is when you actually, it is really indicated to wash your hand. Otherwise, alcohol hand rub can do the job. Now, as healthcare professionals, it is also very important that you get your N95 fit tested. I would like to emphasize the need for the N95 fit test. In case you need to get your N95 fit test, please do let us know so that we can arrange it for you or facilitate it for you. The right side, on your right, is what is called the PAPR or the Powered Air Purified Respirator. This is worn especially if you have failed N95 fit test for all the sizes that are available, or in case of physicians who have beards. So this is what is required if you have failed your N95 fit test. However, it is very, very important to emphasize the appropriate size of the mask to be worn. And in case of non-availability, this is why we tell you to get yourself tested for more than one size so that if one is not available, you can make use of the other. So there are some basic etiquettes that you need to follow. You need to avoid touching your eyes, your nose, mouth with unwashed hands. Make sure once you wear your PPE, your hands don't go trying to adjust your PPEs or trying to touch the front surface of your PPE, which is already contaminated. The other thing is, of course, cough etiquette, which means covering your nose and mouth with a tissue after you cough and disposing the tissue in the nearest receptacle. And once you are done with this, you need to do your hand hygiene. The other thing is when you don't have a tissue, you could sneeze on or cough onto your elbow. However, make sure that you do your hand hygiene after you do this. So this was a circular that was put up in our Outlook regarding what PPE you need to wear. So it is very, very important for us to know what are the PPEs and what are their indications and what type of masks need to be worn when has to be clear. So at all triage points or entry into the hospital is important for you to put on your surgical mask. The surgical mask helps you to contain your secretions, to contain your cough, thereby acting as a source control. The second thing is when you are caring for a patient or just transporting a patient, it is important that you wear the following PPE, which includes your face protection. A surgical mask is good enough if you are just caring for a patient. If you're just planning to enter into the room or not doing any aerosol generating procedure, it is a surgical mask is good enough. And then you can wear your gloves and also your yellow gown or the non-surgical gown. Now, when you are doing an aerosol generating procedure, it is very important for you to put on your surgical gown. The aerosol generating procedures, I will make a mention of what they are. Especially intubation, it is important that you wear your surgical gown, you wear your N95 respirators, your face protection, and your gloves. Okay. So you could also make use of Ebola suits, as these are very limited in numbers. These are specified only to be used for intubation and for aerosol generating procedures. Now, it is very, very important for you to avoid any contamination of your clothing, to be knowing how exactly you put on your PPEs and how you remove them. We follow the CDC recommendations. So before you put on your PPE, it is important that you do your hand hygiene with alcohol rub. Again, the hand hygiene needs to be done for not less than 20 seconds. It has to be done for longer than 20 seconds. Once you're done with this step, make sure that you are in your scrub suits. Always when you are in the COVID areas, try to ensure that you are in your scrubs. Never carry the same clothing back home or to any other area. So it's very important to dedicate your clothes or scrubs for the care of the COVID, in case you are in care of the COVID area or in case of COVID patients. So the next thing you wear after you do your hand hygiene is, of course, wearing a gown. The purpose of wearing the gown is to cover your entire clothing or your attire from and protecting yourself from any splashes that could be generated in the patient area. So you need to put on the gown, make sure that you secure the ties at the nape of the neck as well as the waist. The second thing is the mask. Of course, if you're wearing a surgical mask, make sure that it is a triple layer mask with a metal end at which is the upper end of the mask, and you make sure you tie the ties above the ear, which is at the crown, and another one at the nape of the neck. So always make sure that it is not dangling, or you don't wear it as if it has to cover. The purpose of it needs to be met, like it has to cover your nose, your mouth, and reach up to your chin. And by doing so, you are preventing yourself from exposure of your mucous membranes to any virus. So the third is, of course, you will have to wear your goggles. If you're wearing your spectacles, these do not act as a substitute for goggles, so make sure you also wear the goggles. Fourth is, of course, you wear your gloves. And when you wear your gloves, make sure that it reaches above your or extends up to the cuff of your sleeves. So these are the PPEs that you need to wear and the proper sequence. This will be posted in the group for your reference. And it is also important that you have an assistant. If it is possible to have an assistant with you, it is always important for someone to remind you, to verify what PPE you are wearing, and once you are worn, to correct you if you haven't worn it properly. So an assistant or a buddy is always recommended. Now, how you remove your PPE is also very, very important. You need some time in removing this, and it has to be carefully removed or gently removed, not to be rash or to just, peel it off. So as you all know, the most contaminated part is the gloves now. So you would go close to the medical waste container. You will remove it gently with a pinched technique or glove in glove technique. You will pinch the glove and remove one glove and slide the other finger within the other glove and try to remove it in toto. Now, once you do this, you put it in the medical waste. Remember, all the waste that is generated from a COVID patient goes into the yellow container or the medical waste container. And there are certain things, the PPE, all your PPE will be removed inside the isolation room. Remember, except your N95 mask, which needs to be removed outside the room. Now, once you are done with the glove, you do your hand hygiene. So in the doffing sequence, it is very important for you to follow your hand hygiene after every step of your removal of PPE. Now, following the gloves, you go on to remove your goggles. You slightly bend your neck forwards, you remove it, or you hold it only by the handle, not touching or taking care not to touch the front surface of your goggles, which are contaminated. Once you're done with it, you put it into the waste, the medical waste receptacle, and you will try to do your hand hygiene. The third is, of course, the gown. When you're removing the gown, be very gentle. Untie the gown very gently from the back by removing the ties, and you try to remove it inside out, okay, such that you do not touch the outer surface. You gently roll it into a bundle and then you discard it. And the last is the respirator, which is an N95 respirator. Never touch the front surface of the respirator because it is already contaminated. You grasp the bottom end of the N95 mask and you remove it gently, and then take hold of the upper string and then put it into the waste container, which is provided outside the room. So once you do this, you need to do your hand hygiene and all your steps are complete. So remember, at any point of your removal, when you actually encounter or you touch some if you feel your hands are contaminated or any part of your body, you need to do your hand hygiene. Now, how you go about reporting is, of course, all cases, suspected or positive cases, need to be reported to the 937 by calling 937, and they all get registered into the health electronic surveillance system. As described, all spontaneously breathing patients need to be swabbed by taking a nasopharyngeal swab, whereas in case of intubated patients, we recommend using a deep endotracheal aspirate. Now, these are once you are done with your hand hygiene, wearing on your personal protective equipment. Also, if you see all our patients are directed through a respiratory triage. First, there is a checklist. If they meet a certain criteria or a score of more than 6, they are directed towards the isolation rooms. They follow the respiratory triage, and then they come to ICU. So there is a pathway by which a patient would reach ICU. Now, patient placement, it is recommended that all critically ill patients are placed in negative pressure rooms, okay, which are airborne isolation rooms. If you do not have facilities for negative pressure rooms, you can still afford to place some stable patients in a single room, but taking care that there is a HEPA filter, one at the end of the patient. Also, a logbook needs to be maintained regarding who is entering the room, because this would help us, especially during the contact tracing or when a healthcare worker is exposed to a positive patient. Now, what are aerosol generating procedures? As you see, tracheal intubation, non-invasive ventilation, tracheostomies, cardiopulmonary resuscitation, manual ventilation before intubation, bronchoscopies. All these are airborne or aerosol generating procedures. As a result of which you need to put on all your PPE, which includes your Ebola suit, your N95 mask, and all the other PPE, as I told you. You will wear on, if the Ebola suits are not available, you will put on your surgical gown. Okay, this is because it is impermeable and fluid resistant, and this is very, very important. Make sure that all aerosol generating procedures are done in a negative pressure room, okay, where there are adequate amount of air exchanges that are taking place in the per hour. Now, as long as possible, we try to limit the movement of such patients outside the room. We use designated X-ray or portable equipments. We try to notify the receiving department if you're trying to shift them for any procedure or any such diagnostic procedure that you have to do. Also, make sure that the receiving area has complete information so that they take all their precautions, especially at the receiving end. And we also need to disinfect and clean all the surfaces of the patient. Now, as you see, we already have dedicated equipments, especially for the use of COVID patients, like our X-ray portable X-ray machines, our dialysis machines. All of these machines are dedicated. We also have dedicated an elevator, especially for the transport of such patients only. You can see an elevator which specifies that it should be used for COVID patients only, and so on. This is the transport capsule, which I've actually posted onto the left side. This is mainly for the transportation of a COVID positive patient. Now, on your right, you see people wearing healthcare workers wearing Ebola suits, N95 masks, and so on during the transfer of the COVID patient. So these are the transport capsules, which are mainly used for the transport of such COVID patients to other hospitals. Now, the transportation, as I already stated, you need to make sure that if the patient is spontaneously breathing, you need to put on a surgical mask onto the patient. If the patient is intubated, it's fine. But however, you need to make sure that you put on all your PPEs. You need to put on your Ebola suits if you need, or if they are unavailable, you need to put on your gown, your mask, your gloves, and so on. Okay. Make sure when you reach the other hospital, the endorsing hospital, you need to change your PPE there, wear on a new set of PPE, and then get back to the hospital where you started from. So these PPE are then removed at the EMS or at the point of entry of your hospital. Also, it is very important for you to make sure that we use dedicated equipments only. Carry as much less gadgets with you whenever you are working in isolation rooms. Make sure to disinfect your stethoscopes, your mobile phones, your spectacles, etc. after you have entered an isolation room. Uh, as much as possible, we try to dedicate equipments, but in certain cases where they are not dedicated, of course, we send it for disinfection and so on. So proper environmental cleaning and disinfection is ensured, especially terminal cleaning of such rooms is done. Fogging of such rooms with hydrogen peroxide is carried about. Frequently touched surfaces, especially the bedside rails, the monitors, all of this is taken care of. Now, there are other things which have also been specified, especially after the Wuhan outbreak that happened, or which started in the Wuhan seafood market. You need to avoid touching animals and animal products. Avoid consumption of raw, undercooked, and animal products is also being specified. Now, what happens when you get exposed to a COVID patient? Of course, you need to report to your direct supervisor and the infection control team. The management will mainly depend upon the infection control risk assessment. They would assess you based on whether you had a protected exposure or an unprotected exposure, or whether you have symptoms or you don't have symptoms. Based on that, if you are symptomatic, you need to stop work. You need to get your swab done, and then we would follow up your swab results, and then you would be notified from infection control and cleared from infection control to join your duty. Now, however, the observation period is 2 to 14 days. If you have been exposed to a particular patient, you need to observe yourself for 2 to 14 days for any signs and symptoms or for any clinical deterioration. Now, what if you are staying home, or if you have been home isolated? It is very important for you to do your hand hygiene before you do any kind of activities at home. Avoid visiting or avoid contact with sick people. Try to follow your cough etiquette or respiratory hygiene, and also monitor your health and your family's health. Now, what happens when we have patients exposed to a COVID positive case? Again, you need to monitor them for signs and symptoms, especially for the full incubation period, which is 14 days. If a patient is already negative, you need to follow him again for signs and symptoms for the other 14 days that are remaining. And you need to notify the infection control so that he could be traced and he could be monitored all throughout. So these were some of the things that I wanted to touch upon very briefly. So if you have any questions, you can feel free to ask me any questions that you have. Can you hear me? Hello? Hello?
Thank you, Dr. Ismail. It's okay?
Hello?
Yes, Dr. Ismail, we can hear you.
Yes, sir. Yes, yes. So there was a question regarding wearing of shoe covers. Again, shoe covers are recommended in the care of Ebola patients only, not otherwise. But however, our Ebola suits are provided with the shoe covers, so we just make use of it, just not to waste them. So otherwise, it is generally not recommended in the care of COVID patients.
There is some air in the voice, Dr. Tasmia.
Yes.
If you answer this question, if I go inside the room for a patient with COVID-19,
Okay.
will surgical mask be enough?
Yes. It is right, since it is a droplet borne, a surgical mask is good enough, especially if you're just going to enter the room and come out of the room. However, you need to take your precautions of aerosol generating when you are doing something which activities that can produce aerosols, like if you're doing intubation, if you're going to, as I already mentioned, there are a list of activities or which can produce aerosols. So for all these aerosol generating procedures, it is important that you put on your N95 mask. Otherwise, there is evidence that surgical mask is good enough.
Mhm. Do you answer the previous questions, Dr. Asma? You have it?
Yes,
Dr.
doctor,
Ayman
I'm
asking
not able
how
to
we
see
can,
the question.
Dr. ask how we can use the stethoscope while wearing the bubber.
It would be definitely technically difficult. So if there is someone else with you, or probably I really don't know if you really have to use the stethoscope. We have capnographies. If you can really make use of a capnography just to confirm the tube, or whether the tube is in, you can make use of the capnography that we have. But using the stethoscope will definitely be practically, it wouldn't be very easy to use.
Another question they ask about, do you think to intubate if needed patient only with HEPA filters enough will be safe?
Again, since intubation is an aerosol generating procedures, ideally it should be done in a negative pressure room where there are about adequate air exchanges taking place, about 10 to 12. However, not all institutions have negative pressure rooms and adequate number of negative pressure rooms. So there are chances or there are situations where you will come across a patient suddenly crashing or who needs intubation in while he is in a single room, and there's absolutely no time, or the patient's condition is not stable enough to transfer such patients into a negative pressure room. So in such conditions, we have intubated patients in single rooms, making sure that there is a HEPA filter at the head end of the patient. And in some institutions, what I've seen is they increase the fan speed of the HEPA filter itself. So, or they make two HEPA filters available at the time of aerosol generating procedures. So these are just modifications that are being carried about, but you can go about doing it in case of an emergency, though it is not the ideal or the recommended practice.
Uh, Dr. Abdurrahman asking, do we can reuse 95 mask and can we put surgical mask above
Yes.
95?
This is a very good question, especially now where we really have to conserve our use of N95 mask, and especially when we're facing with supply issues all over globally. So what has been recommended by CDC is reuse and extended use. Soon we will have this policy of extended use or reuse as our policy once it is approved. It is in the process. So once we have this approved and circulated, we will definitely disseminate this. The practice of wearing the surgical mask over your N95 is just to prevent it from contamination and for it to be using, and so that it could be used for extended use or for reuse. So this is why, I mean, you can either put your face protection over it, or you can use, there are different practices which have been used whereby they even put a surgical mask over the N95 just to reduce the contamination of your mask that you are wearing.
About the eye goggle, it is essential in ER. They are always asking during a call to, are they available, and also can we reuse the goggles?
Yes, you can either use goggles or your face protection. Not both, of course. You can use either of them. And of course, depending on your case-to-case basis, if you really are anticipating a splash by the activity that you're going to do on the patient, definitely it is recommended.
Um, some people claim wearing two masks is better. Is it right?
No, definitely not. The most important for you to is to make sure that if you're wearing your surgical mask, it's covering your nose, your mouth, all your mucous membranes up to the chin. Even with the surgical mask, you need to make sure that it's properly fitting you. Try to mold onto your nose piece. Try to make sure if you're wearing your spectacles that it doesn't get fogged, because if it's fogging, it means the failure of your fit of the surgical mask itself. So these are the things you need to make sure of. However, there is no evidence that double masking would actually protect you. A single mask, but definitely a triple layer surgical mask is found to be more protective than other sizes or other masks that are available. When it comes to N95 also, it is no use wearing a surgical mask first and then putting on an N95 mask. So because it wouldn't create a tight seal. Also, when you're putting on your N95, it is very important that you make a seal check. You put on your N95, try to mold the nose piece. You take a deep breath inside, then you exhale, and you try to feel for any air that is escaping around the face. So if there is any escape of air, it means your N95 mask is not fit, and you need to go on to your appropriate size mask, or you need to readjust your N95 mask, and so on.
There's many questions about intubation actually, about the safety of the airway intubation. Either using the plastic sheet or using the intubation box or clamping the tube. Yani, it is long question actually. It needs special lecture, but I can brief if you never mind, Dr. Tasmia. Airway intubation have a special consideration to be touched in the airway management
Yes.
specifically.
Yes,
You
Dr.
can use
Mahdi,
plastic sheet, you can use air.
yeah, there are different modifications to the technique, Dr. Mahdi. One is the intubation box that we are using. This is one of the techniques. In different places, they are creating something like a plastic sheet and a artificial negative pressure area inside the plastic sheet.
Yes, yes. And we have this intubation box in our ICU. Clamping the tube is mandatory. Yani. This is something mandatory. It is not related to the sheet. Okay. Um,
Try to intubate. In
Somebody
some,
asked
yes, we do
about
have the
the.
intubation.
We have many doctors with beard, so how we can deal with those?
Yeah. For the doctors with beards, of course, there is no N95 fit test that can be done. It is very important that you wear PAPR only. That's powered air purified respirator. That's the only solution for doctors with beards. Otherwise, no N95 mask can ensure you 100% fit with a beard. You have to be clean shaven, especially if you're wearing your N95 mask. So that's a criteria or a recommendation, especially if you're wearing an N95 mask, that you cannot wear it with the facial hair on or with a beard or any kind of face or facial hair.
If patient in single room with HEPA filter, I removed my BBE inside the room.
Yes, in a patient with
Doffing.
HEPA filter, this is what I'm trying to say. It is very important, especially for the doffing, that you remove your gloves, your gown, and your goggles inside the room. Whereas the N95 mask or the surgical mask has to be removed away from the patient zones. Definitely away, it means 6 feet away from the patient. So you don't have to be very close to the patient and remove the surgical mask. But however, you need to come away from the patient area, close to the door. You could remove your surgical mask and then come out and then do your hand hygiene. So you shouldn't be removing while you are facing face to face with the patient or having a very close encounter with a patient. You should definitely move away from the patient at least 6 feet distance to remove your surgical mask.
Someone asked about overshoes. If we have the patient, for example, who has ICT, with intubated COVID, do we need overshoes?
What is overshoes, Dr. Madi?
Overshoes,
The
covering
shoe?
his shoes, actually. This is just only, you can comment if you like.
No, covering shoes is that definitely not one of the recommendations for COVID care of the COVID patient. As I already mentioned, it is only for Ebola, care of Ebola patients or patients with dealing with bloodborne pathogens. So it is definitely not a recommendation for wearing shoes or anything.
Yeah, he's asking about, we have many healthcare workers positive with COVID-19. Where are the mistakes in all the world? It actually is not a mistake. It is just not following the infection control protection, especially
Yes, definitely.
during aerosol generating procedures, or getting infected from asymptomatic, which is the most serious. Then in dealing with the COVID positive, you can take all your precautions, but dealing with asymptomatic patient which is unknown, this is maybe the problem.
Also,
But most
as
of
in our hospital, what we see, it was mainly, we can't say it was asymptomatic carriage because everyone, we were recommending universal masking on almost all the areas. The instances that did happen in our hospital were mainly because they were eating together in the pantry, or they were together, I mean, in a group or something inside the pantry, eating together, praying together. So these were the certain things that were noticed. The other is, of course, the patient coughing too much, especially in case of patients who were isolated and they were spontaneously breathing, they had cough. So this could also be one of the means by which it was, a mode of spread to our healthcare workers.
I think, thank you. So, another, can you explain how to disinfect mobile adequately if suspected to be contaminated?
Yes, you can use alcohol wipes. You can use wipes which are available in the hospital as well to wipe. So the only thing is it should have 70% alcohol. You can use alcohol wipes. You can also use the other wipes which are available, like you have Medipal and so on. So whatever wipe is available, you could use them to disinfect your mobile, and then you could use your mobile. But better to keep your gadgets away, especially when you're going inside isolation room, and to refrain from attending your mobiles or any such calls when you are inside, because you will try to touch your PPEs invariably after that, and then you would contaminate yourself, or come in contact with secretions, and then you wouldn't realize. But all these chances could be avoided by just avoiding to use your mobile or carrying your mobile inside.
Thank you so much, Dr. Tasmia. We take almost 10 minutes from Dr. Waqas' upcoming lecture. Thank you, Dr. Tasmia, so much.
Okay, thank you, Dr.
Next lecture actually will be Dr. Waqas, ICU consultant working in King's Medical City. As you know, there is many, let us say, I cannot say theories, but I can say there is many evidence about different pathophysiology for the COVID-19 patient, for the explaining the physiological, the pathological process as well as the management. So it will be a dedicated lecture by Dr. Waqas about this topic. So welcome, Dr. Waqas. I can, we can open. You can share your screen or difficult, Dr. Waqas?
Okay, now it is. Assalamu alaikum. Yes, I will share.
Alaikum salam.
I think it's visible now.
Yes, great.
Okay. Assalamu alaikum. I'm Dr. Waqas, and I'm working with Dr. Mahdi in King South Medical City as ICU consultant. This is a little bit heavy lecture, and at the end of the session, so I need your attention a little bit more than before. So we'll proceed. This is actually pathophysiological approach, and the disclaimer about this one. This is actually the observational study and observations made by one of the German anesthetists, Gattinino. And as we process through these slides, you'll come to know what is actually going on inside the chest after the COVID infection. So let's go with this most popular slide you'll find in almost all presentations. This is published in New England Journal of Medicine, and explaining a little about how the COVID-19 virus enters the cells, and it attaches its spikes with the ACE2 receptors, and finally it gets entry into the cells, replicates, and finally it causes the downregulation of the ACE2 receptors. As these ACE2 receptors downregulated, the angiotensin 2 will be accumulated, and it will cause its effects by different receptors. In the next slide, it explains at better level, and it's published in Journal of the American Heart Association. As we know, angiotensin is acted upon by the renin and converts to angiotensin 1. Finally, the ACE1 acts on it and converts to angiotensin 2. At this step, angiotensin 2 needs ACE2 receptors to convert into a good product, which is angiotensin 1 to 7, and it will cause vasodilatation, anti-apoptotic, of course, factors, anti-fibrotic, anti-proliferative. So this will result in the decrease in blood pressure, decrease cardiac fibrosis incidence, and decrease thrombosis incidence, and decrease ARDS. So what happens? The COVID-19, once it causes ACE2 receptors downregulation, the angiotensin 2 will be accumulated, and it has more propensity to act on angiotensin 1 receptors, and just the opposite effect of this product. It will cause vasoconstriction, inflammation, fibrosis, proliferation, and of course, it will cause increase in blood pressure, cardiac fibrosis incidence increases, increased thrombosis, and increased chances of ARDS. So this is the way the virus is affecting the cells. Now, these ACE2 receptors will find in the brain, will find in the lungs, will find in the intestines, will find in the kidneys. So of course, all these organs are affected, and of course testicles, but no study is done on the what happens to testicles, but ACE2 receptors are there also. Let's proceed to the disease course. Disease can take usually three type of courses. One is the hyperacute, where severe hypoxemia from the beginning, breathlessness, and patient will be intubated or go into respiratory failure. The other course, it is moderate to severe hypoxemia, but patient only moderate upper breathing and stays in the same state until it cures. The third one is biphasic, where it is the most dangerous initial indolent course, like 5 to 7 days with severe hypoxemia, breathless, and leading to, and finally 5 to 7 days after that, patient enters into the this first indolent phase, and then enters to hyperacute phase and hyperinflammation phase, and finally respiratory failure. So this biphasic phase is the most dangerous. Now we can say minimal changes to ARDS picture. As we can see on this side, we can see the minimal changes in the X-ray, and here the full ARDS is there with consolidation collapse. So there are different kind of pathologies, and these are the CT cards of chest in different patients. And for example, we can see the consolidation, we can see ground glass and crazy paving appearance in the lungs, and even mediastinal lymphadenopathy had been seen. So this is the gentleman, Luciano Gattinino, who with his colleagues, he presented the theory that this is not simple ARDS in the pneumonia of COVID-19, but this is beyond this, and we have to take care while managing this patient. Every COVID pneumonia is not ARDS. So he publishes findings in ATS journal, and he says that every COVID is not an typical ARDS. We will explain further. He found that the different factors actually modify the disease pattern. He classified into A, B, and C. He found that this is the combination or interaction of all these factors. And he found that severity of grade of infection, how much severe is the infection, one, how the host responds to the infection, and how much physiological reserves he's having, how much strong, how much immunity he's having, and what are the other comorbidities like heart disease, respiratory problems, kidney disease, or something, any chronic issues. Sorry. And then the interaction of the patient lung with the ventilator. And the third one, the onset between the disease and once the patient has been observed in the hospital. So all these factors will lead to the fate of the disease in any patient. Okay, these factors are summarized well in the Massachusetts General Hospital COVID-19 protocol. They published this protocol on 10th of April. And they say, they classified these risk factors in the epidemiological, vital signs, and labs. These epidemiological factors, if age more than 65, pre-existing pulmonary disease, chronic kidney disease, uncontrolled diabetes with the hemoglobin A1C more than 7.6, history of hypertension, history of cardiovascular disease, obesity with BMI of more than 30. This patient is on monoclonal antibodies or any biologics, and patient is post-transplant and having any immunosuppression drugs, or having HIV with CD4 count less than 200. One of these epidemiological factor, and patient got COVID-19 and now is having respiratory tachypnea more than 24, tachycardia more than 125, or saturation less than 93, or PF ratio less than 300. Then one of the epidemiological factor, or one of the vital signs is present, then high risk of progression of the disease. Or on the other hand, if patient is having one of the epidemiological factors or one of the labs are deteriorated to the extent D-dimer more than 1000, CK more twice the upper limit of normal, CRP more than 100, LDH more than 245, and absolute lymphocyte count less than 0.8 on admission, ferritin more than 500. So one of the epidemiological factor or one of the vital signs deteriorated, or epidemiological factor or the lab is deteriorated, then there are chances that patient has high risk of progression of his disease. Now, this slide again, as I have mentioned before, there are ACE2 receptors in the lungs, brain. So of course, they will cause its effect. So just to summarize the effect, there will be imbalance between VQ, there will be hyperfusion, low ventilation, and there will be microthrombi processing, and finally it will cause increased dead space and collapse and consolidation, and ARDS picture will give to the shunt. And as neurotropism effect and the ACE2 receptors are there, COVID can cause anosmia, it can cause the patient delirious, patient can have the problems in cognition, and of course if midbrain is involved, it can cause the respiratory problem and even the respiratory cardiac arrest. And this interaction with the ventilator will explain in the next slides. So this is a very important slide which will give you the full pathophysical picture as such. So as I mentioned, there will be high perfusion, low ventilation. So what will happen to the patient? Patient will be having hypoxemia. This hypoxemia will cause him to take more deep breath, and work of breathing will increase with the increased tidal volume. So once in increased tidal volume, increased negative intrathoracic pressure, there are chances that this will cause the lung injury to the patient. This lung injury is because of the patient increased work of breathing. We are not causing anything, but patient itself, because of increased tidal volume, damaging its lungs. So this is called patient self-induced lung injury. Similarly, neurotropism, as I mentioned, it will cause increased respiratory drive. It will add to the work of breathing, and the same phenomena, increased tidal volume and patient self-induced lung injury. Then if patient goes into the sepsis, then what will happen? Increased metabolism, and same cycle will start, patient self-induced lung injury. And the other hand, the corona COVID-19 itself, it causes acute lung injury. So these patient self-induced lung injury because of increased tidal volume, increased work of breathing, and direct effect of the COVID-19 will cause acute lung injury. And this is a combination, and the lung injury happens because of the combination of these two things. Now, this patient self-induced lung injury phenomena was initially described by Barak in 1938 and Mascheroni in 1988. And they found combination of negative inspiratory thoracic pressure and increased observability due to inflammation result in the interstitial lung edema. So this patient self-induced lung injury is a very important factor which is being considered nowadays in the COVID-19 damage of the lungs. Now again, the factors which I have described earlier in the two slides of Massachusetts General Hospitals and this one, interaction of these factors and patient once it's intubated, ventilated. Finally, time-related disease spectrum will be of the two phenotypes. One is the L type, and the other is the H type. What is L? Just remember now for the time being, L for low for everything, and H is high for everything. What are the components in the low? And what are the components which will be high? We'll discuss further. So just L for low for everything, H for high for everything. Now come to this slide. Once hypoxemia will be there, there's dysregulation of pulmonary perfusion. So it will cause the low elastance of the lungs, low VQ. The lungs will be low recruitable and limited PEEP response. So this will be considered as phenotype L. Next, if there are pulmonary microthrombi and ARDS, the typical ARDS happens, consolidation, collapse, everything. So combination of this will leads to this type converted, this type L type will be converted to phenotype H, which is typical ARDS, pulmonary edema, collapse, ARDS picture. So everything will be high there, high elastance, high VQ, high recruitability, and high PEEP response. So this will be phenotype H. Now, how these two, one type is converted to another, we'll explain further in the next slides. Let's see this lung injury happens by patient self-induced lung injury or the by the direct COVID-19, impaired gas exchange in the lungs. Just 1 second, sorry. Okay. And increased respiratory drive. And this increased respiratory drive, increased tidal volume, it will lead to patient self-induced lung injury. It will cause increased esophageal pressure swings and increased pressure on the trachea. It will cause increased leak and lung edema. So we can see this non-typical ARDS will be converted to the typical ARDS. Sorry, some issue with these slides changing. Okay, now the Gatinino and his colleagues observed and they presented one case, and it is showing that at the beginning of the COVID infection, we see the CTs. One cut of the CT chest, it is showing very big area is aerated and only consolidations are found in the few areas, and they found the PF ratio at that time was 95 and patient was having FiO2 of 80% or 0.8. After 7 days, you can see the PF ratio from 95, it changed to 84, not much changed, but the CT is totally destroyed now. We can see there are very less aerated areas of the lungs, and all the part of the other lungs are now consolidation, collapse, mixture of pneumonia, everything. So within 7 days, the L type, which was this type, converted to H type. So what they did and how did they approach these two type of things? First, they given the 15 liter of oxygen to the patients, and they said their target was the saturation to be kept more than 95. And if on 15 liter of oxygen, they were able to keep the saturation more than 95, they said this is mild. And if they were unable to maintain this saturation, they said this will be considered as moderate to severe. Now, if, for example, if they have labeled this mild, they manage it with the high frequency nasal cannula or CPAP. If it's moderate or severe, they directly intubated the patient. And what they did, how did they monitor? They said we can monitor this, the work of breathing can be monitored with the esophageal manometer. I think it is not available with us. And the other way, the simple way is the center line, which is put in the subclavian vein, and we'll have to see the inspiration and expiration swings in the central venous pressure. So if these swings are less than 10 centimeter, we can use, this means the patient is having low work of breathing, and we can use high frequency nasal cannula or CPAP. If swings are more than 15, then directly go for intubation. These were the observation by Gatinino. Okay, now the question will arise, should we use this CPAP or this high frequency nasal cannula? So I'm deviating from my topic a little. We'll come back to this topic. Let's see what the KSMC guidelines say to us. So avoiding non-invasive positive pressure ventilation in many circumstances is recommended. Exceptions where, for example, if you need short-term bridge to ventilator availability, for example, ventilator is not available and you need some time, you can use non-invasive pressure ventilation or high frequency nasal cannula. Or a patient is having something which is reversible, like flash pulmonary edema, mucus plugging, or witness small aspiration, then this is a rapidly reversible thing of and which can be corrected by high frequency nasal cannula, non-invasive positive pressure ventilation. And the other thing, obstructive sleep apnea, tracheomalacia, of course, we'll use this non-invasive positive pressure ventilation. But there are recommendations where to be used. First of all, BiPAP machine with dual limb with HEPA filter. Second, should be negative pressure room, strict isolation, and including N95 mask, and ensure masks and devices fit well and there is minimal leakage. Now, If the things are out of control in a way, saturation less than 90 or FiO2 more than 0.4, then increased work of breathing will go for intubation. Rapid progression of COVID-19 will go for intubation. pH dropping to 7.3 or less with PCO2 more than 50, of course, intubation. Hemodynamic instability, multi-organ failure, and clinical judgment of the patient, of the physician will also lead us for the intubation. Now coming back to the topic. So just remember these guidelines while you are working in ICU. Now coming back, now they found the patient is having this moderate to severe COVID-19 pneumonia and is not maintaining on 15 liter of oxygen. And finally, the patient is intubated and mechanically ventilated. The initial settings they have made: tidal volume of 8 ml per kg, PEEP of 8 centimeter, respiratory rate initially, and to keep the volume, end-tidal CO2 around 4 to 5 kilopascals. And what were the targets on the mechanical ventilator? They wanted the saturation of 90 to 94, PO2 of around 60, PCO2 of 45, and they wanted the plateau pressure to be kept less than 28. So after managing in this way and getting the targets, they checked the driving pressure. They found if driving pressure is less than 15, then it means the things are under control. So they kept the tidal volume a little bit higher than ARDS protocol, 8 ml per kg. And for example, if driving pressure they're not achieving less than 15, what they did, they reduced the tidal volume to 6 ml per kg body weight, which is the recommendation in the typical ARDS management. Now they found that in spite of these targets achieved for a little time, then the patient deteriorated and saturation dropping again less than 90, and FiO2 in spite of increasing and now reached the level of 70% or 0.7. So they added neurovascular blockade, increased the PEEP, which was initially kept around 8 or 6, whatever. It was gradually increased by 2 centimeter of water stepwise up to the level of 15 centimeter of water. At this level, their targets again were the saturation to be kept around 94, PO2 60, PCO2 45, plateau pressure less than 30, and of course the driving pressure less than 15. And at this level, saturation was still less than 90 and FiO2 has reached 0.7. So what they did, they checked the compliance of the lungs. Compliance, if more than 40, it means this is compliant lung, and they considered this is considered phenotype L. It has low elastance, low recruitability. So in this case where compliance was good, more than 40, they continued with the tidal volume of higher range, a little bit of higher range, 8 ml per kg, and PEEP not to be increased more than 8 to 10. So you will find this totally different what the way we are managing the typical RDS. So if compliance is more than 40, so it means it is compliant lung. So it has low elastance, low recruitability. So tidal volume is kept a little bit higher with PEEP in 8 to 10. On the other hand, if compliance is not more than 40, it means non-compliant lung. So here your typical ARDS protocol will come into action, and this will be considered phenotype high with high elastance, high recruitability, and patient will be more responsive to the prone position, and it will be PEEP responsive. So rather than 8 to 10, you can follow the ARDS protocol. You can go up till 14, 16, 18, 20 according to ARDS protocol. And we can use the APRV mode of ventilation on the ventilator. So this is the way they decided that every ARDS in COVID-19 is not typical ARDS, but the management will be different based on pathology. If it is low type, then we don't need to give the low tidal volume, and we don't need to give higher PEEP in the L type. But if it is H type, wet lung, then we'll go for typical ARDS management and follow the ARDS protocol with low tidal volume, higher PEEP in the H type. Now further, they mentioned that if hypoxemia is refractory to zone position, or patient is already on APRV mode of mechanical ventilation for more than 6 hours, or sooner if life-threatening, then we'll have to decide about the code status or ECMO status. So we need to consult the ECMO consultant, and he will guide us that ECMO can be done in this patient or not. Is this extracorporeal membranous oxygenation system can be run on this patient, then we can go for VV ECMO. If not, then we'll have to discuss with the family and discuss among your mortality committee or your DNR committee, and we can decide about the DNR or the supportive management in the ICU. So let's summarize the thing. Early recognition of hyperacute disease, need for immediate intubation and high risk of cardiovascular event. This is necessary. Short and judicious use of CPAP or NIV, as I mentioned, by keeping in mind the negative pressure room, HEPA filter, dual tubing, everything. And of course, there are conditions where you can use CPAP in the according to KSMC protocol. And early differentiate of L phenotype, because it is very important. If you think this is a compliant length, then no need to give this very high PEEP or the low tidal volume. Keep a little bit higher tidal volume in L phenotype with PEEP of around 8 to 10. This is not typical ARDS. So remember, it might be stormy now, but of course, the sun will shine, inshallah, and rain doesn't last forever. And again, the disclaimer. Thank you.
Thank you, Dr. Waqqas. Thank you so much.
Thank you, Dr. Madhu. Any questions?
Any questions, Shabab? If you have any queries, you can write in the chat room. We have one question. Can you just summarize the mild to moderate patients? How do you treat?
Actually, this is mild and moderate to severe. This is based on Gatinino observation. What they given, we can go to this slide actually. Okay. They considered if we given the 15 liter of oxygen, which is maximum in our gauge, and if saturation is maintaining more than 95 on this, they considered this is mild. Okay. But this is not only the factor. For example, if I given 15 liter and patient has good reserve of his good build in the respiratory muscles and good reserve, of course, he will keep on breathing and will try to maintain his saturation more than 95 but extra work. But we have to judge it clinically. So there is no clear cut demarcation between what is mild and what is moderate to severe. This is just a guideline that if patient is maintaining 15 liter of oxygen and with saturation more than 95, we consider mild. Moderate to severe, we have to go for the intubation. Yes, anything else?
Brief, the summarized oxygen therapy. The main management for the mild to severe or mild to moderate. Oxygen therapy try to improve his hypoxemia with different type of the oxygen therapy, even as we can call the awake proning. You can use it in some patients. We have another question. Yeah.
Okay. Question, I think it will come in the management of ARDS
Yes.
or the other topic, but just briefly, the thing is, they are recommending the proning in the awake patients even. They have seen even our one of our colleague, Dr. Fahd, is working actively in this hospital with the COVID patients are managed, and he shared us with the pictures. Even the patient is playing on mobile, and he has proned himself, and we have seen the difference in the PO2 and even in the saturation. So even if your patient is awake, the early proning is better. So this is highly recommended. Regarding this intubation and keep using this nasal cannula or face mask, it also, I think you should judge clinically rather than the going for the guideline. And I think the guidelines will be discussed tomorrow, Dr. Madi, I think so, maybe.
Yes, it will be discussed tomorrow about the management of the hypoxemic patient. Hypoxemic patient. And another point I want to highlight will be we are not only treating the hypoxemia with oxygen therapy, the most important in the early phases is work of breathing. And sometimes for that they are calling it happy hypoxemia. Sometimes they are keeping your patient with saturation accept 70, 80, even 75. We can accept in some situation if he doesn't have increases work of breathing.
Yes.
It's not tachypnic, is not acting intercostal muscles, is not acting like that. And another patient with maybe he can hypoxemia is not severe, but we need to go early for intubation because of work of breathing. One something very important on those patients, which is because it can induce itself. Yeah, I think now you can see
This slide.
Yes, yes. Great, Dr. Rojas. This is I want to say.
Yes. So this is the thing Dr. Madi is highlighting. As mentioned, hypoxemia, neurotropism, and sepsis all will lead to the work of breathing. So patient will try to give more oxygen to him. So what will do is increase tidal volume, self-induced tidal volume when the patient is breathing himself. So it will cause patient self-induced lung injury. So to avoid this, if you see the accessory muscles are being used and in spite of patient maintaining 95% saturation and patient is having increase of breathing using accessory muscle, opening mouth and mouth breathing like this, I think go for intubation to save him from patient self-induced lung injury, which is also one of the big factor in the injury to the lung.
I think last question, Dr. Rojas, يعني something is advanced. Talk about tracheostomy. Tracheostomy type for L or H type. It is not related, but you have
It is not related. Actually, this is a failure of weaning, or you are going for ECMO. You will say patient will stay on ventilator for the long time. This is a different, and there is no. They have not studied, and actually, it is not. I think it is not related to L or H type, whatever. Depends upon the recovery of the patient or how the patient is behaving with the disease. So
Yes.
this tracheostomy has nothing to do with this.
Yes. Okay. Thank you so much, Dr. Rojas.
Thank you, Dr.
for
Madhu.
all.
Thank you, everybody.
Thank you, boss. Great
Thank
job. I hope you register with your name to just monitor the attendance or report the attendance. Again, inshallah, we'll have another 2 days with different lectures. We'll touch most of the ICU basics tomorrow and after tomorrow also, and we will end with the MSQ by that. Can you have any queries? Thank you so much. Inshallah, tomorrow 9:30. Kindly, please be on time. 9:30 p.m. We'll start our second day. Okay, and once you will join the ICU or you'll be on the list of the standby surge list, we will have another orientation for the COVID-19 protocols. Okay. So in the protocol, we have everything, touching everything for the COVID-19 patient management. Okay, so don't worry about the work in ICU. Whatever you're doing with us, we need your support and we need you inside our ICU. Even minor work, it means a lot for us. So thank you so much and see you tomorrow, inshallah. Thank you.